Buenos días a todos.
Good day to all of you. Welcome to this webinar and welcome virtually to the Wilson Center. I'm Andrew Rudman. I'm the director of the Mexico Institute at the Wilson Center. And it is truly a great pleasure to be with all of you. We have today an excellent panel of experts in the area. And I believe that we are certainly going to have a very interesting conversation, quite intense, and I hope it will be also impacting. It is a pleasure to collaborate within this event with the America's Health Foundation, our partner for quite some time. Now, Wilson Center, for those of you that do not know us, is in itself a creation of the American Congress in 1968 in order to commemorate and recognize the life of President Wilson, and who he was the only U.S. president that had a PhD. Now, the Wilson Center, basically, the context of it is to provide a space for the merging of ideas, the discussion, and public policy. And since President Wilson was a member of the academia, and he also put in place the practice of public policy as a politician and as a president, this event is precisely a representation of this. We shall have a conversation regarding varicella with the intention of sharing the challenge that the governments of the Latin America governments are facing, and to take into consideration possible options and solutions that we hope that you will take into account and that the governments will also consider together with other stakeholders within the region. Having said this, it is a true pleasure to now give the floor to our dear friend and co-sponsor, Dick Salvatierra from America's Health Foundation. It's a pleasure to have you here with us. Thank you, Andrew. Good day and welcome to this forum on policies. I'm Dick Salvatierra. I am the chair of America's Health Foundation. We are a foundation located in Washington, yet we work throughout the whole Latin American region. We are a foundation working in public health sector, and we are a bridge in within the industry and the opinion leaders. Let me thank our expert panel that will be introduced to you in a moment more. And we certainly thank you for accepting this invitation and to participate with us. Let me also thank uh, Merck for its support and sponsorship to our America's Health Foundation, so to hold this event. At the same time, I would like to uh, thank Wilson Center and for their personal and professional support to moderate this event, and that you have worked so much with our Director of Governmental Affairs, Felicitas Colombo. This is quite an important topic and relevant topic that does have an impact in all of Latin America. And having said this, let me give the floor now to Felicitas Colombo. Thank you, Vic. Thank you, Andrew, for opening up this session and the panel. At this point, in order to begin, I would like to introduce the expert participants that are panelists of this meeting, starting with Dr. Alejandro Cravioto, the expert team in immunization of the WHO, Dr. Cristina Mariño of the Pediatric Association in Infectious Diseases at the National Committee of Immunization Practices, Dr. Mirela Vázquez Rivera, former chair of the Mexican Association of Pediatric Infectology and current treasurer of this organization, Dr. Enrique Chacon Cruz, pediatrician and researcher in inoculation of the Siena University, and Dr. Mario Melgar, member of the Guatemalan Association of Infectious Diseases and the National Board of Immunization Practices in Guatemala. To begin, I would like to start talking about this area at the global level. Vaccines in the world and in Latin America as the region that is of our interest. I would like to open up this roundtable with an affirmation that allows no discussion. You know, immunization is a relevant area, saving millions of lives at the global level. We currently have vaccines to prevent over 20 deadly diseases, potentially speaking. And we would like to highlight two pillars that will be present with us during this session. Two premises of the WHO. The first of them, immunization is the basis of primary health care and a human right that allows no discussion. The second, immunization is one of the best investments in public health in which governments can participate with their prevention programs. Nevertheless, even we have had major steps. About 20 million of children every year have no access to vaccines. Now, let me give the floor to Dr. Alejandro Cravioto so he can share with us the recommendations of the WHO and the trends of vaccination in the world. Dr. Cravioto, the floor is all yours. I thank you. Felicitas. Good day, good afternoon to all of you. Let me clarify that my function as chair of the Strategic Advisory Group was over in December of last year after 7 years of leading the group, which was a major honor for me. Now, in regards to what Felicitas was expressing, there is no doubt, I believe, that inoculation, vaccination, has been a healthcare intervention that has saved lives since we started using them by the end of the 18th century. The use of products that prevent frequent infections is what has allowed us also to extend the life expectancy in most parts of the world. And above all, it has allowed us to have a growth within our children that allows them to reach their full potential that they're born with. I believe that these areas and what Dr. Colombo has mentioned is the cost effectiveness of these products, what turns them into something essential in our health programs. There could be a very small group in the world in comparison with those that are using vaccines that is opposed to this use of vaccines, but we're winning this battle. The clearest example of the advantage of inoculation has been during this pandemic that we are uh, 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 seeing how this has developed and it's ending, but it was in a record time that we were able to have access to vaccines. And that is actually what saved the lives of thousands of people that any other way would have died given COVID-19. At the same time, the problem of the pandemic has created a tremendous delay in our inoculation systems, globally speaking. In accordance to the last published figures by the WHO and UNICEF, there are at least hundreds of thousands of children that have not been vaccinated in the last 2 years. In itself, that represents a major problem and a serious danger for not only their health, the health of the children, but all of us. So the recommendation of WHO, therefore, is that every country has to put in practice a system of vaccination that will allow us to identify and inoculate or vaccinate all of these children that are still pending. And we're seeing this right now. We are beginning to have cases of polio in the United States, cases of polio circulation in Germany, in Israel, something that we hadn't seen before. And in reference basically with the fact that people that are not vaccinated are now suffering this. The most serious problem of the lack of inoculation is not polio, myelitis, though it's still a global problem, but the cases of chickenpox and smallpox. Those of us that live through this is one of the two major causes of death, more so in children that have problems in regards to their inoculation. Uh, uh,
Gigantesco esquemas de vacunación.
we have a major step, vaccination schemes at the national level, and therefore what we need to do is to be fully dedicated to see that these children that are pending of vaccination will be a part of this. The pandemic has also given us a severe economic problem. There's an increase in the amount, quality that is below poverty levels, and this is being reflected in the levels of malnutrition that we had not seen in a long, long time before. All of this is becoming a problem of a circle of problems that will lead us to an increase of child death that we had not seen since we started the achievements of the millennium, which was an initiative that we had in order to achieve an improvement in the children's health sector. From this perspective, this type of events certainly help us to put into practice what we do want to have in place, and we wish that the recommendations that will come out of today's call will be useful for those that are with us, and that will be reflected in an improvement of the health system. That is really what we are interested in. I will leave it this far, and I appreciate your invitation. Thank you, Dr. Cravioto. The immunization WHO agenda for 2030 establishes an ideal and an ambitious strategy at the global level in the area of immunization and vaccination for the children's sector. You have anything to relate to us in regards to this WHO 2021 agenda that was created during the pandemic, and more so in particular for the region? Anything that you can share with us? Well, the program has two changes in regards to what we had in the 10 previous years. The program is done from the bottom to the top. Uh, this is to consider what was the most important thing. The second is that part of what I have just shared with you is the new message that the program contains. And within these days, we are just about to have a meeting of the group that is leading the 2030 immunization program in order to adjust whatever will be needed in this regard. What we have insisted upon and what we've seen in the last advisory group meeting last year was a clear need of vaccinating the children that are pending a vaccination, and more so the fact of trying to incorporate the vaccines that are accessible and that are yet not part of the vaccination system. There are many countries that still do not have vaccination against rotavirus and others against pneumococcus, and these are accessible vaccines and that fortunately are a part of the ones that are offered by the Gavi vaccine partnership that provides vaccines for those countries that are going through economic problems or the biggest economic problems. Now, as we will see, there are a series of vaccines that are quite accessible, and that the cost for using them and purchasing them will be minimum in regards to the prevention of diseases such as varicella. Now, this is in itself an area that is quite accessible. It is ready. This chickenpox vaccine is present. So those countries that have an adequate vaccination system, they have no reason not to incorporate all these others elements. And finally, what is quite pleasant is to see the future scenario. For the very first time, perhaps in a very limited time, we will have vaccines against respiratory system vaccines at the B streptococcus, and vaccines that will be against the herpes virus, also Civella, and also strains, and also new vaccines such as TB, which is one of the vaccines that could give us a change in the scenario in infectious diseases at the global level. And this is in itself an important part, not only of the scientific development, but also of the use of these products for something as important as the prevention of these diseases. The time has come for us to truly use these things that will allow us in a given moment to improve all of these voids in public health through the use of effective vaccines. We thank you, Dr. Cravioto. Thank you so much. And I have two data to place us within a global scenario of what the WHO is reporting. We estimate that the global coverage dropped from 86% in 2019 to 81% in 2021. And we estimate that by 2021, 25 million children have not received basic vaccines. Uh, I would like to open, therefore, the session of finding out what happened in Latin America and to have an introduction of what is happening in terms of varicella, of chickenpox, as an example of all of these changes that we are seeing in the immunization programs. Let me give the floor to Dr. Mariño from Colombia. The floor is yours. Good day to all of you. Thank you for inviting me. It's a true honor for me to share this panel with experts such as Dr. Carabioto and all of my colleagues. And I will share with you, and I will use for this a few slides in order to relate to you what has been happening with varicella prior to the introduction of vaccines and how the introduction of vaccines against chickenpox has been in Latin America. Let me now share my screen with you. Very good. I think that you can see my screen. I'm sharing it. Dr. Cravioto has shared with you how we're introducing vaccines at the global level. And part of what we wanted to share with you is that for 2014, the WHO had already said that we had to introduce varicella or chickenpox vaccines within the country, and the number of doses was up to the target to introduce them. You know, we can introduce more than one dose in a new program, but what we want to do is to reduce the mortality and to reduce the number of blocks or outbreaks. But the Infectology Pediatric Association proposed the introduction of vaccines against varicella in the Americas with different doses, with the consideration that chickenpox is a very important disease, as I will be sharing with the different data. I don't know what happened, why my screen is no longer shown. I believe, Doctor, that we didn't see the slides, but another website. So we'll be sharing it on your behalf. Wonderful. I do not know why. There you go. If you can expand this image. So the next slide, please. First, I was sharing what the Latin American Pediatric Infectology Association stated. Here, let me share with you, if you can expand the image. I cannot see it clearly. Very good. There you go. Thank you so much. I can see it so much better. So now what the Latin American Pediatric Infectology Association stated. Next. And here we can see what we knew in regards to the reference where we're including many of the Latin American countries, which is one of the most integrated publications of whatever happened with varicella in the Latin America. And several of the infectologists in Latin America were a part here, and they were headed by a doctor in Costa Rica that talks about the Latin American diseases with a systematic review. And here we see some areas. One of the areas that we all know of is that since chickenpox or varicella has not been a mandatory reporting disease by case for many years, there is a sub-recording process here. So it makes difficult to estimate the real burden of this disease in most of the countries. Some countries started doing a study of measuring antibodies in order to know which has been the burden of the disease, given some data. And well, it is therefore very important to have the yearly incidence estimated by every 100,000 inhabitants of reported cases, and the studies of seroprevalence showed that the major burden of the disease in Latin America is basically with diseases at all ages, but more so children from 1 to 4 years old, and that for Latin America in adult age, about 80% have had chickenpox with major differences. For example, we can see that Puerto Rico was reporting a lower seroprevalence that of about 100% in regards to other countries. Now, this is the incidence of varicella by age group in the different countries. Now, this is prior to the introduction of vaccines. Colombia, my country, is showing cases of varicella at all ages, but with very important presence in the age group of children below 5 years of age. And this reduces with age. We see the same case in Panama. It calls my attention that in Panama, there's also an important presence in adult population. Peru, major presence in children below 5 years of age, as we have shown in the article. Next slide, please. And here we see the varicella-related mortality indexes where we have zero prevalence. But what has to do with this? Let's recall that varicella, by many persons, it was considered not a serious disease, and that it was not even important for children if they had it. And once they had varicella, they were immunized, but it's associated with mortality. We as pediatricians see mortality given varicella. It's important to prevent through the use of these vaccines. Given the mortality, we see the case of Argentina, where the highest indexes of mortality take place in those children below 4 years of age. And the same happens in Peru and Brazil, but there is a presence of varicella at all ages. So we must consider varicella as an important disease also in the mortality burden levels. Next slide, please. And here, let me share with you the Colombia case, which is also estimated in Colombia, where we have the most affected group. We have this data prior and after the vaccination process. We have uh, uh, the number of mortality levels. Basically, they die of pneumonia, encephalitis, uh, complications of unspecified fever. But one of the most important things here that Dr. Cabiota has mentioned is that another problem of the pandemic at the global level in Latin America was not an exception to this. There was an increase in children malnutrition and a low coverage of all vaccines. So it is much more feasible that malnourished children within our countries where we have areas of better conditions of health, more inoculation, yet areas where these numbers went down considerably. So we need to have this into account. Given this scenario, what we are coming across, and next slide, is that there have been studies that were demonstrating not only varicella mortality, but also the burden at the cost level, that has to do with hospital cases, all the death cases, and this adds up to mortality in Latin America. What these children are doing, they have pneumonia, encephalitis, different varicella, fasciitis, shock toxic, and septic toxic elements. And well, you can see zero point 0.9 million of persons in Latin America, and in the US it's only zero point 0.4 per million of persons. And we see that we are at the top of the pyramid because many cases of the mortality associated to varicella are not reported as deaths caused by chickenpox. Now, also, prior to introducing vaccines in Latin America, several countries, and among them Argentina, Brazil, and Colombia, consider which are the estimated costs of this disease. We know they're very high. Basically, given complications that are also all of the direct and indirect costs, specialized management. Many of these patients die in IC units, laboratory tests, and all other expenses. Next slide. And given this scenario, we see that of what has happened since the beginning of the year 2004, 2005, for many of the countries in the region that have introduced vaccines against chickenpox. Well, we see how we were in 2010 in the introduction of vaccines against varicella, and how in 2022, 17 countries that I'm now referring in Latin America and the Caribbean had introduced vaccines against varicella. Next slide. Here we can see this was in itself a major advancement since the year 2004 and up to 2014. And well, in 2022, we had vaccines in 17 of the countries. And one of the things that for me, when we had this review was quite impressive was that most of the countries, 10 countries, already have a plan with 2 doses. And in the other countries, we have a single doses. We know that Peru, for example, this year will introduce a second inoculation, a second dosage. So through this, we have a complete different scenario. And next slide, we will see what I will be sharing of the different countries, basically. But there are many countries that are having an impact in the introduction of varicella vaccines, given the fact that not all countries introduce this on time, but perhaps one of the countries that has published its information is Costa Rica. In these two graphs, clearly we can see how there was a decrease in the left-hand side graph, the cases of varicella, and we can see that we had more cases in children below 4 years, and the strain follows the important reduction of cases in Costa Rica, and not only of the cases, but also hospitalizations and casualties. And well, now given this high coverage, we reduced over 70% the presence of varicella, and not only among children, but in all ages. And well, you can see what is most relevant here. We had a reduction of mortality indexes and hospitalization indexes. So Costa Rica shows us the major impact of these type of policies as they are implemented in Latin America. Next slide. Here, let me share with you the other countries. Uruguay, that was about the first country to introduce varicella vaccination in Latin America. The arrow shows the moment when this was introduced and how the cases were down in all ages, but more so at the ages of children between 1 and 4. In Colombia, my country, we saw the same case, a reduction since the moment of the introduction. The blue line is general population, and the green line, children from 1 to 4. We saw an important decrease in the presence of varicella cases. Now, also, we have studies of cost post-inoculation that I have shown you the major impact that it had as a disease in the hospital expenses. Within this study that was conducted in Argentina, and it shows the important reduction in costs. And the conclusion is that to vaccinate against varicella within the study and other studies in Brazil and Colombia is that is less costly, far less costly uh, to inoculate than to pay for the disease. So we consider that these vaccines are certainly cost effective. My conclusions, I will not read them to you. You have them here. And I believe that we will be sharing with you now, even though that there are no complete data and we don't have the right follow-up of the presence, varicella is truly a very important disease, and the inclusion of vaccines should be a priority. And obviously, we have many studies that are showing us the major impact of inoculation against varicella in several countries, basically in all of the countries that have published studies in Latin America. Thank you so much, and I hope I can share additional data in our discussion. We thank you, Dr. Mariño. Very interesting slides and regional data. Let me highlight at this point a comment that you made constantly during your participation, and that is that many of the countries do not have a mandatory reporting uh, process of varicella, and many public policy decisions and public health decisions are taken with this data that are not reliable. So therefore, I would like through this to start a conversation with Dr. Mirela Vasquez, Mexico. She will share with us the case in Mexico where the varicella vaccine is not within the immunization national calendar. Dr. Mirela, welcome. You have the floor. Thank you, Felicitas. Good day to all of you. I thank you for allowing us to, uh, as members of Mexico, to share with you what is the problem in relation to this vaccine. Well, the truth is that Mexico does not have the vaccine in a mandatory way within our national vaccination program. Since 2012, in a meeting, the first meeting of the National Council of Vaccination in Mexico in 2013, that uh, varicella was only for the risk population, where we have the children that go to a daycare center, uh, and also immunological compromised patients. After we finish, our formulary says that the vaccine is indicated whenever we have vaccine availability in the country. That has been a very important problem. Long before this, our country has inoculated in the medical private offices children that go to them, and we estimate that that is no more than 1 or 2% of the population that should be vaccinated. So therefore, we may conclude that Mexico is not a country that has vaccinated its population in regards to varicella. So what we can have now is epidemiological studies. In the year 2015, we met a group of experts in infectology. Dr. Chacon was a member of this meeting when I was the president of Pediatric Infectology Association, looking for ways to promote the fact that the varicella vaccine will become a part of our vaccination scheme. What we realized is we needed to have epidemiological studies, evidence, to be able to convince that it was cost effective to introduce this vaccine. And therefore, we started to generate all of this evidence. As many infectologists of the association, this includes Enrique and myself. This is one of the first studies that we conducted regarding epidemiology in our country. We took the official data of the epidemiological surveillance system in Mexico. These are connected, Felicitas, with what you were sharing in relation to the fact that given that it is not mandatory to have this report, and that is in the pool of reports of preventable diseases, given the presence of inoculation, and don't have a special report as we have it with measles, as Dr. Cravioto was sharing, there is a very important report, smallpox, I'm sorry. And well, here we have other studies. Now, their first approach to this is what is happening in Mexico, which is this one, where we found that what is reported in our country is an average of 300,000 cases on a yearly basis, which is totally unbelievable, but that is the case. Now, let's say that the affection to young children between 1 and 9 years of age, our graphs are the same as what Dr. Marino shared of other countries, children from 1 to 9 that most frequently have this type of affections. We came across an atypical annual behavior in the country from March to May, where we have the higher incidence or presence of varicella or smallpox chickenpox cases. And this has to do with a previous study. Something else that we have seen is how it has been reported by most countries prior to introduce the vaccines. There is a cyclic format every 3 or 4 years where we have a peak of the presence of this disease. But well, you say 300 yearly cases in a country that has a population of over 126 million people. That was the estimate in 2020 by the National Statistical Office and Geographic Index. But we have other studies of seroprevalence in Mexico. This has been shared with you by Dr. Marino, in this study by Dr. Lascano, where we have a global prevalence of 85.8%. That's our zero prevalence. By ages, it is reported. But in looking at this graph, the only thing that we can see is that most of the Mexican population, we have considered that it is a benign children's disease that's even self-limiting. But unfortunately, it's not the same story for all. Why is so? Because many of the patients do have a complicated disease and even has consequences or collateral effects. And there is a study where we included 5 countries of Latin America and Europe, and we participated with Mexican cases in this study of varicella in Mexico. And in this Marvel study, we have shared that most of the complications are skin and soft tissue infections, abdominal pain, a good number of children with systemic infections, uh, and they also have dehydration and encephalitis. But within the study, we also have found that there are patients that have 2 or more complications. And not only this, but the collateral effects are quite important. Of these patients that we have at the National Pediatric Institute, we find that, yes, the mortality is low, 1.67%. Patients evolve quite well, but 40% do have uh, collateral effects or as consequences. This is the percentage of the institute that we have here, where we can see that the complications in the soft tissue are truly important and they leave consequences, and the cost of health care for these complications is very high. This is only a slide of the Marvel study where we can see that those studies that have a serious condition, well, the cost goes up given the fact that they need to be at an ICU pediatric unit. You can see this in the burgundy bar, that is Mexico. Almost 10% of the hospital's patients have to be directed to an ICU pediatric unit. Well, which we know certainly increases the cost. Obviously, our hospital stay in the Marvel study, for example, in Mexico, the duration of hospitalization is 6.7 days or 6.4 days in intensive care. That percentage, that 10% that came into ICU. So it is not a simple matter. Now, at the end, our study of the economic burden of varicella in Mexico among the different countries, we have broken down the data of the country in itself. And let me share with you that with this study, Peru promoted the entry of the vaccine to its national vaccination scheme. And with these data, they managed to incorporate this. And I'm so happy to see that of the 5 countries that were a part of this, their reaction was quite immediate given the outcomes. In Mexico, we have other studies after the epidemiological studies, and in 1 of 2 hospitals of 3rd level concentration, which is of direct costs and complications in Mexico, well, the average cost is not so different from the Marvel study, only that we cannot transpolate this so easily because there are 3rd level hospitals where we only have patients with complications. And well, given the fact that they have an immunodeficiency or they became very complicated cases given varicella. So we are focusing only on this data, while within the study, a Marvel study that we conducted with the 5 countries, we took cases of the private sector, of the 1st, 2nd, and 3rd healthcare level. So it is far more the reality of the cases that take place within a country. And well, we looked for how much is spent or how much do you need in updating healthcare services, doctor visits, hospitalizations, visits to in ICU, intense therapy, laboratory studies, procedures, and also the consulting with other experts when the cases are very complicated. In summary, we found that the direct cost of healthcare of a patient in average is $198.31. I'm saying this in dollars because we have English speaking audience, or 3,088 Mexican pesos for the exchange rate at 2017 when these data was published. And the case of the patients that are at the hospital are of 5,610.99 or 110,000 pesos. Here we're using the table of the Social Security Institute. We didn't go to private sector medical expenses. These are the tabulators that are formally used for the studies conducted regarding costs. And well, the indirect costs in this case were estimated in the case of ambulatory patients, 2 days, and in regards to the hospitals, the number of days that you remain in the hospital. So here, the cost is important. We were only missing in this regard to put these costs in place because these studies are the basis or the epidemiological basis that we need of a cost efficiency and cost benefit study. Fortunately, we have this in Mexico. That was done by Dr. Enrique Chacon. We have a first approach, a political approach, where in inoculation there are several elements. First of all, the real data of the need of having a biological element, also the economic participation, but a very important element is political will. So there is a first meeting in April of 2020 that was proposed by the lower house to introduce this vaccine. We had no response to mandatory varicella vaccine introduction, but I believe that after the study that will be presented by Dr. Chacon, where we can see that it will mean important savings for the country if we would implement this in regards to the introduction of vaccines. So in summary, in Mexico, many of us professionals that have to do with pediatric and vaccinology, we're dedicated to find ways that we will introduce vaccines for these children. I do not know if with the problem that we have shared in regards to COVID, the low coverage, Mexico not only had low coverage, but it also had lack of supply. Uh, so we expect to have a difficult response in regards to raising the coverage and to introduce new biological elements. We thank you, Dr. Mirela Vasquez. Very interesting. Let me highlight that if we go back to the mandatory reporting, these are limited data because they're based on official data in a country where the reporting is of this disease, it is not mandatory. Yes, there are sub-recording elements here. Let me go now to Dr. Enrique Chacon. Let me give you the floor. Dr. Enrique Chacon Cruz has conducted a study, as it was presented by Dr. Vasquez, of economic evaluation of universal varicella vaccination in Mexico. It has been published in the Pediatric Infection Disease Journal, where the burden of the disease is checking the cost effectiveness of the varicella vaccine recommendations in order to approve vaccination in the standard calendar of vaccination in Mexico. Let me give the floor to Dr. Chacon. You're most welcome. And the floor is yours, doctor. Thank you. I'm sorry. I thank you for being invited. I thank the Wilson Center and also the America's Health Foundation and also my colleagues, Dr. Cravioto, Dr. Basket. Something to highlight of this study is that this study does not have any bias from the pharmaceuticals or nor the industry. I conducted this study with the Siena University in Italy and with the participation of the P19 from Louvers, Belgium, that is expert in the study of epidemiological models for macroeconomic studies, etc. Now, there is no bias from the pharmaceutical industry here. So having said this, I will not explain the slide here, but the varicella disease burden in Mexico is basically based on what has been mentioned by Dr. Mariño and Dr. Mirella, which is the low reporting or the sub-record. We can go from 200 to 300 by 100,000 with zero prevalence of 70, 80, 90%. So obviously there are sub-records in such a way. This is not only happening in Latin America, but all over the world. But we have designed studies, and this started in Europe in 1959 in Belgium with the disease burden of varicella and other diseases based on zero prevalence. For this, we have used the study of Dr. Lascano and Dr. Conde, in which the zero prevalence by age group is a study that we fortunately have in Mexico with a catalytic method that is added by age. And based on this, we have an estimate, not 100% certain, but very close to the reality in place. Now, if we look at the following slide, we can see the estimated annual burden of varicella results in Mexico based on this catalytic model obtained from a zero prevalence in the population. So here we understand in Mexico, we have about 129 million people or inhabitants for this line. And we have a year in Mexico over 2 million cases that are reflected in 1,180,000 doctor's visits, about 5,300 hospitalizations, and close to 200 deaths. By age group, the most affected are young children, as it has been mentioned before, but nevertheless, the mortality is higher in the adults above 20 years of age and young children, as it has been mentioned. So the burden of the disease in this internationally well-accepted model is far higher than what we know of. Now, the economic burden is very important to mention that we have to use tools. The tools are what we have at hand. Fortunately, we have a study of economic burden that is a major tool to estimate the burden, and some of the costs were obtained from a Brazilian study of Verbatim, and there is data of a Colombian study and another one of Dr. Grillo in Argentina. But mainly is a study of Dr. Mireya Basket, the ones that helped us to be able to estimate this economic burden of varicella, and the direct costs are the ones that are related with hospitalization or the treatment of the patient, that is in blue. The indirect cases can only be included, as Dr. Mirela Vasquez shared, the labor lost of the parents, or the indirect costs such as the transportation costs, etc. And well, all of this economic phase is really much greater. This burden is much greater from the economic perspective. And here we're going to see this by age group. And in total, we'll see that in Mexico, every year, we spend at least over $165 million US dollars only to treat varicella. Now, once we have the economic burden of the different disease, we have to evaluate what will be the value of the single varicella vaccine in regards to the cost effectiveness or cost benefit. And for this, we have used two vaccination strategies. Number one dose of the single varicella vaccine at a 1-year-old, along with measles, mumps, rubella vaccine, MMR, and well, and also, so we have the triple viral vaccine and then the varicella vaccine at OP. at the OPS price. We separate this at a year and once, and then at 6. Now, that's 2 doses of a single varicella vaccine along with MMR. Number 3, 1 dose of a single varicella vaccine at 1 year along with MMR, and quadrivalent measles, mumps, rubella, varicella vaccine at 6 years of all. MMRV in a single syringe. But the price of this vaccine that we were able to get is what we get in Mexico privately. This is much lower. This is what we have obtained from the rotatory list of PAHO and what we could get at a private price in Mexico and at 6 years of age. The results that we obtained are quite impressive. It's a major study. Let me just share a couple of slides. First of all, is the best benefit cost ratio. The BCR per vaccination strategy is money against how much I'm expending, how much I'm saving. So if the reason is above 1, it's a benefit cost ratio. If it's below, there's no benefit cost. In regards to money, against money. Now, let us forget about the red bar here, which are the hospital expenses or charges. But the social expenses are direct and indirect costs. Let's focus only in the blue bars here. Strategy 1 is to apply a single dose at PAHO price, which is way above 1 cost benefit. Strategy 2, 2 doses a year and at 6 years at PAHO price is above 1.6. So it's benefit cost ratio positive. Strategy 3 with tetravalent viral vaccine at a private price did not turn out to be cost benefit positive, but nevertheless, one thing is to have this table that is talking to us about savings for Mexico's government and society. If they include the varicella vaccine for the strategy of coverage in the 95% coverage, 85% coverage, that is the analysis, and we will be saving from $30 to $53 million a year vaccinating with these coverage against varicella with the strategies 1 and 2. But the cost effectiveness term, well, this cost effectiveness term is based on the cost per life year gain and ILYG. This is pharma economy term, but we want to see the highly recommended threshold for life year gain. When we don't have this figure, what is recommended is the GDP Mexican per capita. For that year, it was $9,673. This is the other way. What is below this threshold is cost effective. What is above is not cost effective. So here we will see the total data for the total cost. That is the blue bar. And if you realize, the blue bar is way below with the strategy 3, which is a PAHO vaccine a year of the viral prevalence at 6 years is way below, way below. So this is no cost benefit apparently, but it's cost effective. But strategy 4 that has 2 doses at 1 year at 6 years, but at a private price, did not turn out to be also cost effective. My conclusions are the disease and economic burden of varicella in Mexico is high, much higher than what is reported by far. The UVV with the 4 different vaccination strategies proposed result in a high reduction of cases of hospitalization and death. Strategies 1 and 2 were found to be cost saving and strategy 3 to be cost effective. The strategies 1 and 2 would allow savings annually of $53.16 million a year. And something really very important, and this was shared by Dr. Cravioto before we started this call, but we need to reconsider that the price of this is of the inoculation with reductions. Well, it will not only be cost effective, but this viral quadruple inoculation would also be cost beneficial. And also UBV should be seriously considered in Mexico, not only given humanistic or social perspective or in the health perspectives, but also because it implies a risk and prevention and savings for the Mexican society. Let me finish by saying this. Let me just mention what Dr. Mireya Vasquez had mentioned. A federal Mexican representative, Carlos Ivan Ayala Bobadilla, approached me to publish this, and it has been published within the Congress, but it is not even an initiative. Congress was paralyzed and nothing has happened. We thank you, Dr. Chacon. I don't think there is much to add. The data speak by itself. Then we will have a roundtable where we can share all of these systems. And let me also invite our audience to post their questions for the panel. Let me introduce the Guatemala case with Dr. Mario Melgar. Guatemala is another country where varicella's inoculation is not within the standard calendar. I would like here to uh, have Dr. Mario Melgar sharing with us what is actually the situation in Guatemala. Dr. Melgar, the floor is yours. Thank you very much. And yes, I believe that we have already shared what has happened in other countries of the region. The case of Guatemala shouldn't be in any way different. Let me share with you what we have in our country. I think I should be able to be sharing my screen with you. Yes, we can see it okay, doctor. There's always a doubt of making sure that we are sharing our screen the way we want it to look like. Uh-uh. Well, Guatemala is a smaller country in regards to Mexico. We in Guatemala were 16 million inhabitants in the last census. We have 108,000 square kilometers of surface. Now, the vaccination against varicella is present in a small group. The private sector has a vaccine since the year 2000, and we have been able to inoculate a good number of the population. The Social Security in 2018 made an important effort, and it started inoculating, but it reached about 10% of the population. So the public sector covers uh, about 80, is not covering 85%. So the access to the vaccine is very low in the country. And added to this, we have the problem that we don't have a varicella surveillance that in reference to other countries in regards to varicella. That is the no data of the disease burden given varicella. And as a reference in routine, but regretfully, just as what has been mentioned before, we are still thinking that varicella is a light disease. We consider it that it heals itself. We don't hear so much the varicella parties that we will say, oh, one cousin had varicella, and now everybody is going to have it. You know, you all attend, so you don't have to suffer this when you grow older. So, I mean, we still hear, not as much as it was before, but basically, given the fact that there is no important access to inoculation, this is a reality. As a reference, if we could inoculate against varicella, well, we have the first doses above 80%, reaching 90%, but now given the pandemic, well, we have a second doses about 70 or 80%. So at least we know that 85% of the population could have access to a vaccine. Is quite similar to the case of smallpox. Now, what do we know about varicella? Well, what we're trying to do is trying to get more information, given the fact that we're trying to promote the possibility of varicella inoculation. For several years, we're trying to get some data. We had an opportunity to gather some data regarding the disease burden in hospital patients. We wanted to look also ambulatory patients, but it's very difficult to find data of ambulatory patients, given the fact that this is a disease that since it does not either get to a doctor's office, it is not registered by a patient with varicella or chickenpox, and that's it. So in the evaluation of patients in 4 hospitals in Guatemala City with a health unit And as an anecdote, well, we have two patients with Oster herpes in the oncological unit because they are uh, immune committed. And it's not only varicella, but there are other elements that could create problems apart from the fact of keeping them isolated in order not to disseminate the disease. But it's very painful with complications of different infections. This is just to let you know that we have two patients with this. We have patients with varicella diagnosis, and well, in the last 5 years, we have had 155, and we have evaluated different general costs, and with no surprise, we found patients with more cases of young children. It's kind of even in regards to gender issues, male and female, and also with access to the health sector. We have seen that normally there are more males that come to doctor's office at all ages, including pediatric, and we have identified 80% where we conducted the study. There's an area where we have a higher population of Latino population. It's an urban area, but there's a good number of non-urban population, given the fact that these are reference hospitals so that we were evaluating. Most of these patients that went to the hospital, most of them had a normal nutrition, and perhaps some of them had overweight, and it is a percentage of almost 20% of malnutrition. None of the immunocompromised study. We included a cancer hospital with a good number of patients with cancer, almost half of them. Also, half of them with no immune compromise. And well, this study is a part that we want to share, not only in the immunocompromised, but we have patients with varicella. They could be healthy and get varicella. But those of us that are within this panel are quite sensitive because we see these patients with far more frequency. You know, children that are healthy and get complicated. Complicated indexes, I think it's quite interesting to see that 66% of patients with complication is a very high number. And well, we have 76% of complications, almost 60% with more than 3 complications, a large number of complicated patients that get to the hospital. And well, therefore, we assume that these could be patients with a high complication level. That's why they're getting to the hospital. But well, what we have seen, varicella in itself is certainly an important disease. There are complications with infections in the soft tissues, some pneumonias, some encephalitis that could be very important to see them. And as a matter of fact, we also see them in health patients where we see complications of infection diseases in immunocompromised, but encephalitis is in health patients and some other cases, such as sepsis, cerebellitis, hepatitis. Now, other infections, complications, well, and hematological alteration, that's the most frequent one. Interesting also to see that they needed to be sent to an ICU, about the equivalent of 20% of the subjects. Is very high, you know, for a disease that, you know, are taken to the hospital because they're immunocompromised patients. To come to the hospital to get to ICU is in itself an important number. And well, the experience that you have in other countries, but I think it's quite similar in all of Latin America. The patient comes to ICU is because they're seriously serious. We don't have a lot of ICU beds, and we keep them for seriously sick patients. This is a consideration that we must have. There are normally highly complex patients that are quite serious, and they end up in an ICU unit because they are precious beds. The days of stay at ICU is from 1 to 5. You know, this is 10% of the total. Almost half of the ICU stayed from 1 to 5 days, and more than 5 days, half of the patients. This is quite long, the time spent in ICU, and the ones that needed surgery, most of them didn't. And here we have an issue of cost. You know, cost per case, including costs taking different sources to try to define them. in each case, and to remind you that these are hospital patients and the cost is $2,711. This changes from country to country, but still for us in Guatemala, this is quite a high cost. And well, patients in the hospital estimated for a public sector, at the private sector, this would be multiplied by 3 to 5 times. So this is the cost in the public sector. So, well, we want to have the following step to take is that all of this data will be useful for a study that we will try to follow Enrique's cases and try to do something regarding cost effectiveness, cost benefit, in order to promote the issue of vaccination. What are we doing in Guatemala? Well, we don't have a surveillance regarding varicella vaccination. We're going to have different studies. We're going to try to have a surveillance. Basically, in regards to a vaccine, we need to have a surveillance previous, during, and after. We want to continue our studies because not having surveillance, we will depend basically of different studies in order to conduct our in, research, but we'll look for additional sources in our studies to look for prevalence and also the evaluation of cost benefit, cost effectiveness, and cost versus use recommendations. And the next step in the vaccine board or council in Guatemala, we have made a list of priorities. Varicella has been one in positions 1, 2, 3 in recent years. We also say, remember, varicella is something that we need to discuss. And of course, the pandemic delayed all issues, and we have some pending issues in the risk patients. And part of what we want to do is precisely to evaluate these areas that are pending that we needed to reconsider given pandemic issues. And well, this is part of what we hope to be doing this year in evaluating the possibility of recommending varicella vaccine in the country. And then it will be up to the vaccine program to take the final decision. We hope it will be positive. Maybe not this year, but maybe next year we will introduce a vaccine that for all of us as pediatricians, we see it as something so important, and we see the major need that we have of this. But all of this is really important for a population that as pediatricians, we see all these complicated issues to develop a true awareness and to reach something similar to what other countries are doing, where we'll see the possibility of acquiring the vaccine through the rotatory fund, the combined vaccines, with the MMV processes, with cost benefit for all of us to be able to evaluate that we're trying to improve our culture in regards to the prevention of chickenpox. And well, hopefully we will see that we will not have to go through a new vaccine process, but we can have this within a vaccine that is already known, where we will have all of these benefits. This is what I wanted to share with you in regards to Guatemala, but similar to other countries in Latin America, maybe less number of data. And hopefully with this data and sharing data from the region, well, these are very important issues to see what other countries are doing, what we can learn from them, and well, to introduce a vaccine, hopefully, in our country in the near future. Thank you, Dr. Melgar. Thank you so much. And here, let me highlight that there is an approach with the government, and we are having conversations in regards to the introduction of the varicella vaccine, and that we can follow this. With no more, let me give the floor to Dr. Mariño regarding the cases of Colombia and the cost effectiveness prior and after the introduction of the vaccine in Colombia. This is the epidemiological studies presentation of cost effectiveness. Dr. Mariño, the floor is yours, and I believe that your microphone, very good, thank you, we're on. Let me try to see if I can share my screen directly. I hope you can see it. Felicitas, yes, we can. Thank you very much. At this moment, what I'm going to be sharing with you is the data of an interesting study conducted in Colombia, which I find very interesting of what has been mentioned here, what is happening in other countries with Dr. Mireya regarding Peru, and what a country can share with us in other countries in regards to the introduction of the vaccines. Let me congratulate the Mexico and Guatemala group because you have solid data already published, which is really very important for countries in Latin America. Let me share with you the epidemiological studies of cost effectiveness before and after the introduction of the vaccine in Colombia. This is very important because given the solid data that we have in Mexico and Colombia, they're introducing vaccines. We will have very good data of what has been the impact of the introduction of vaccines in Colombia. We had been discussing the introduction of vaccines against varicella from different outbreaks in the National Vaccination Committee or Council. We introduced the national scheme since July of 2015 for the children that at this time were 1 year old. And if this was in itself a discussion that we say that justified several meetings of the National Immunization Practice Committee for us to introduce 2 doses. Given costs and given a committee, we couldn't go back to one single dose. And it was nevertheless somehow difficult because given the cost, they said, let's start with 1 dose, let's see how we're doing, and then we'll go to a second one. But once the vaccine was introduced, it was clarified that we were going to be using 2 doses and that the second doses was going to be applied starting in June of 2019. And this is a study published last year. That is a study that we had been doing for quite some time. It estimates the impact of universal varicella vaccination on the clinical burden of varicella in Colombia. A national database analysis 2008-2019, considering the mortality given varicella in Colombia. Here, part of the study, we had the different goals for May 2008 to 2015 pre-vaccination, and then up to 2019, given the single post dose of the vaccine. And the events measured here were cases and casualties or deaths with a target population 1 to 4 years of age. We considered also the population that was not target population about 4 years of age. And also we looked at the impact in all of the general population with the data in regards to incidence and mortality were obtained from the data of the National Health Institute regarding the surveillance given mortality and all of the national statistical information published in Colombia. The important part and the material of all of these studies was what was done, because since we knew that it was not so reliable, and during the pandemic even less, and though we knew that they were not reporting all the cases as we have shared this morning. So what we did was a study that was an analysis of this self-regressive integrated moving average model called ARIMA in its acronym to assess the impact of the incidence of the disease if we would have not introduced the vaccine, estimating what was happening, and we made a forecast of what happened if we didn't introduce the vaccine. This is part of the 2008-2019 initiative, and how basically what I'm highlighting here on the slide, and this has to do with our official data, that since we introduced the vaccine, and obviously during the first year, the second year, the coverage was not so high, and then we worked in 273,000 675 cases, and well, the highest decrease took place with our target group, children from 1 to 4 years of age, where there was a decrease of 23.6% in all cases during the period of the study. And here we can see this as by every 100 inhabitants. It's very important. What was also a major impact was the decrease in the deaths, as we can see in the graph, what happened before and after. The red line are the children from 1 to 4, where the mortality decreased in a very relevant way. Within this age group, there was little percentage of deaths in the non-objective group. So through this, we were able to explain that from a meaningful perspective, this really made sense. Now, if we wouldn't have introduced the vaccine, we would have expected what could be forecasted in accordance to what we were doing in 2008. This is obvious on these bars, and we can see how since 2017, that at this point we had coverage of 90%, where we were able to see a yearly important reduction in the presence of varicella, when more cohorts of children were inoculated, and a serious reduction when we had the first 5 years after the first dose was implemented in 2019, where there was a reduction of more than half of the cases that we expected to have after the vaccination process. And since 2017, well, our target population is where we have seen the highest impact of the vaccine. So here you can clearly see within the columns of the two green bars what we could have expected if we wouldn't have vaccinated, and what could have happened if from 1 to 4 years of age we wouldn't have inoculated them, and what we found after the introduction of the vaccine. And this is perhaps the most important result of this study, that the estimated number of cases that we managed to prevent in the general population, and taking the whole of the population and knowing that the cases where we had the largest number of cases were from 1 to 4, and it was about 200,000 cases of varicella, that if we wouldn't have vaccinated them, we would have had to receive in our medical healthcare centers. And here we can see the mortality levels, what we would have achieved, and what we have seen if the vaccine would not have been introduced. And obviously the highest impact in the mortality descent in regards to what we would have expected if we would have not inoculated children in the group of children from 1 to 4, where we managed to reduce the expected mortality in over 40% in the total population. That it was not such a major impact, but this is because we didn't have such high levels of mortality in this group. But nevertheless, you can see that the line drops to basically zero, which means that the impact in against varicella in the mortality levels is very important. So this will, if we would achieve high coverage with 2 doses, this would be a disease that we wouldn't have this mortality levels caused by this disease. So the most impacting issue within the study is, allow me to share with you how the coverage was not achieved during the first years, but by the end of the period. And when we reached 2019, that we had the second dosage, we were above 90%, which is very important. So this is an economic evaluation. We still have not published a study of how cost effective is universal varicella vaccination in the real data that we have, but we will see if the entries to ICU care and hospital were considerably reduced with immediate elements. But this is an interesting study because it helped us, as a matter of fact, in Colombia, to put pressure for the introduction of these vaccines in our national vaccination calendar. And how cost effective is varicella vaccination in developing economies and countries. And well, here I believe that this could help other countries. And the summary is that within the absence of vaccination against varicella, there will be over 700,000 cases a year and an approximately large number of casualties. So the study estimates that the effectiveness of the vaccine, estimating it at 85% levels and 95%, 90% levels, will be vaccines that will be definitely cost effective. And at the end is presents that it's not only cost effective, but it's also cost saving at the level of it. And I think it's very interesting to see that this will start expanding what has happened after the implementation of the vaccines and the reduction of costs in Colombia. And I did not want to end my presentation without sharing with you one of the problems that we may start discussing, and that of all of Latin America is having, and it's what is happening with the migrant population, not only with varicella, with many other diseases. We have a serious impact in migration, and this is indicated by our health system in Colombia. And they say that in 2019, we notify 185 cases of the migrant population. That is a very high level of population from Venezuela that are migrating from Venezuela to Colombia. Many of them are not inoculated, not only against varicella, but many other diseases. And what our government says is that in the notification of cases from abroad, we increase the number of cases coming from abroad to 340%. But it's important to identify this and report all of what we have with the migrants, with all vaccines in regards to our border centers and checkpoints. I have, thank you. We have shared all of this information. And we can see that the impact of the vaccines in a country that has introduced them 5 years ago has been quite considerable. Thank you so much. We thank you, Dr. Mariño. Let me thank all of the panel members. Unfortunately, we have limited time, and I have an observation that I would like to share with you, and then I will ask all of the panel members to issue a recommendation in possible in 1 minute. If you can recommend us an important point. What we have heard in all of the presentations is a series of data and facts, and for us, for all of us, that is really important. The decision makers, the politicians that develop public policies will have data upon which they can base their decisions. I certainly thank all of you panel members for sharing all of this data and for assisting us in the relevance of the varicella vaccination. Let me ask each and every one of you to give us a public policy recommendation that you believe that you can implement in your country and in general terms. Let's do it in the same order we started our presentation. So we give the floor to Dr. Cravioto. I believe there are two important things, Dr. Rotman. Number one, we need to make sure that our population that has not been inoculated in the past recent years will get vaccinated to avoid future problems. And the second point is to see within the economic possibilities of each country, which are the new vaccines that need to be incorporated as soon as possible to the national vaccination system. And as it has been mentioned during the presentations that we had, to add varicella vaccination as part of the vaccination against rubiola, measles, and smallpox will have an immediate impact that will be of benefit for the children of either of our countries that have not yet incorporated this particular vaccine. Thank you, Dr. Cravioto. Let me now invite Dr. Vasquez. I thank you so much. The truth is what Dr. Cravioto has shared is very important. We have to see children in all areas. And well, something truly urgent now is to consider all of the topics that are somehow behind in time given the pandemic because we may have problems with diseases that have a higher impact within the health sector and the economy, such as the smallpox and other diseases that we consider that we don't have in the region. Yet we have worked intensively, so varicella will be a part of the national vaccination scheme. And it is really very important to realize that it has a very important disease burden of a second disease, given the fact that herpes zoster could be impacting other ages, not only children, and also it has possible complications with complications. It's not only the cost, but every family breaks down actually by whenever they have a member of his family that has consequences of the disease, and it calls for special attention. So this increases the cost to our society, and we have evidence now of that we can do it. So we should be quite uh, thoughtful because the cost has increased in Mexico almost 10 times, for example, with the introduction of the 13 biologicals that we have. So it's very important to look for funding and to have political will because there are many programs, social programs directed to our population that quite often are less important than this one of the prevention in the health sector. This is my comment. We thank you, Dr. Vasquez Rivera. Now, let me give the floor to Dr. Chacon Cruz. Dr. Rodman, you're talking to us about hard data. You call it hard data. And well, the hard data is present. It has been presented in North America, in Mexico with Dr. Mireya Vasquez and myself. We've talked with persons involved in deciding vaccination, and the response is there is no data, but yes, we have data, clear and convincing data. What we do not have is political will, and that is something that we, as doctors, feel frustrated, very frustrated. And the second part of the answer has been given by Dr. Cravioto, far better than I could express it, which is to update the vaccination program. There are many people that have not vaccinated, a large migration problem. We have a very serious migration. I was raised in Tijuana, which is the most transited border point in the world. We have to approach this, and nevertheless, let me express my gratitude, Dr. Rodman. Thank you, Dr. Chacon. Now, Dr. Melgar has the floor. Well, I believe that we can recommend several things, and what is important to be said. But let me insist in surveillance, which is very important, which is a common denominator, which is optimal surveillance in the region. Then also to keep on insisting, as Enrique said, in the political will, and to have activities such as this one. I mean, we've had an opportunity here to see the introduction of several vaccines, and normally we follow a process that includes to create collective awareness regarding the presence of different diseases, and I appreciate all of the opportunities that are contributing so we can reach not only our population, but also our government officials, and given the introduction of all of these vaccines. Thank you, Dr. Melgar. Now, please, Dr. Mariña, your final comment. Well, I believe that many things have been said. Let me share this in 4 points. To improve surveillance, not only surveillance, but also surveillance and reporting, easy access to reports, and I would like to have data of Colombia and Peru. I'm looking at information from other countries that helps other countries to improve and increase the coverage. We cannot talk about how we're doing with a vaccine if we have low coverage. And also education is very important, not only to the community, but also to the age group, to the medical group, healthcare professionals that consider varicella not to be important as a disease. So we need to continue educating by publishing everything that supports what is done in other countries in order to achieve that each of our countries will take other decisions. I believe that having said this, I summarize what we all have said, and I certainly appreciate everyone's participation. It was a great experience. We thank all of you. In order to conclude, we have now a scenario of what is happening within our region, and we thank all of the experts, the panelists, the Wilson Center for providing us your platform to have these important conversations. And we hope that through having these conversations, we may open up the doors to generate beneficial changes for public health sector, and in this case, for the introduction of a varicella vaccination in countries that still do not have it, with clear data, with clear benefits. Now we are going to share with you a video clip that will share the regional reality of the region with varicella data. And we hope to have this conversation in the near future. And let me thank all of you for your participation. Varicella in Latin America and the Caribbean. As the population of Latin America and the Caribbean is growing, the same goes for the needs related with health care in the region. Though access is broad, in recent decades, the events have expressed and made more serious the existing problems in the health systems of the region. In the field of immunization in public health sectors, the regulatory policies and limited data and the lack of access of the population are some of the ways that prevent the optimization of the system. An example of this is the routine vaccination against varicella, which is a self-limiting disease. Nevertheless, it should not be considered as a benign disease. Its repercussions could be very serious. Varicella could be associated to complications and even death, and it presents us with an important economic clinical burden in hospitalizations, and also the national program of children vaccination. The most common complications are skin infections from 3 to 61%, followed by breathing infections from 0 to 15%, and neurological problems 1 to 5%. To illustrate this, we estimate that the global incidence of varicella is between 2 to 16 cases by every 1,000 persons. The regional variation can be attributed to factors such as age, the climate, and daycare centers. The available data regarding varicella in Latin America and the Caribbean are limited. The estimates indicate that the presence of varicella in children below 15 is of 42.9 cases by every 1,000 persons a year. That is a mortality index of 0.5 deaths by every 1 million children from 5 to 14. Children below 5 are the most affected. Now, the burden of the disease is higher in those countries where the vaccination, varicella vaccination, is not a part of the intensive vaccination program of the public health system. For 2019, 16 of the 35 nations have vaccination against varicella. As an example, Brazil had a reduction of the hospital indexes of 47.6%, from 27.33 to 14.33 by every 100,000, 3 years after the introduction of a single doses of children from 1 to 4. Given the fact that varicella is not a mandatory reporting disease, as it is the case in other countries, the information is limited only to the hospital cases. On the other hand, many countries of the region, such as Mexico, Guatemala, and Venezuela, are not vaccinating against varicella, and only 10 countries use the 2 recommended dosage system internationally recommended to reduce the cases with the potential of eliminating the disease. The inclusion of vaccination against varicella within the national calendar does not guarantee getting full immunization levels. They certainly promote an important reduction of cases, which could prevent casualties and contribute to a positive impact in public health. The challenge for the countries that have implemented universal vaccination is to keep high indexes of coverage, to control the efficacy of the vaccine, to control the outbreaks, and change the patterns of it. This is particularly important after the COVID-19 pandemic that has given the creases of the coverage as important as the 20% in some countries. The pace of this drop of the coverage is not easy to get back. The way in which we're recovering this is up to the policies and government strategies in the public health sector. The challenge for the countries that have not implemented the universal vaccination in their normal calendar is to control outbreaks and to consider and identify the disease at an early stage. Complications are a burden for the health sector, and it is unnecessary for the health of the patients and their family. Finally, these patients will be benefiting from the implementation of two regulatory immunization programs. The supervision of varicella is essential to respond in right time to the viral outbreaks. It provides the tools for control measures that will reduce the presence and the complications of the disease. Currently, the indexes of varicella are less reliable given the sub records and mandatory reporting from the health officials. In Latin America, there's an important need to have regional collaboration. It has to do with consolidating all of this data that will allow countries to generate solid strategies, working partnerships, and reduce the burden of the disease.